ahead and get started. I'm Phil Dellinger. I'm one of the intensivists in the Viner ICU. I recognize most of your eyes. So airway pressure release ventilation, this was the first publication in 1987 in critical care medicine. I was in my second year at Baylor and Bentab in Houston, and actually was one of the peer reviewers on this paper, and probably I had only started doing peer review within the year when I reviewed this paper. And John Downs was 3 years from having been president of the Society of Critical Care Medicine. Christine Stock, who I got to know quite well, was his fellow at Ohio State on the anesthesia critical care program. But what they set out to do at the time, there was concern that with ARDS, that the high peak pressures that we saw on the ventilator were problematic both for hemodynamic compromise and for barotrauma. Did they think it was bad for volume trauma? No, because volume trauma, no one was thinking about volume trauma or injury to the lung from using too high tidal volumes. And it was also before plateau pressure was routinely measured. People tend to think about risk for hemodynamic compromise and barotrauma meaning that the volume and the pressure is popping alveolar sacs. So they just said, we think this type of ventilation technique would allow you to get the same oxygenation with lower peak pressures. That was the whole concept behind this paper. So they had normal large animals shown on the left, and then ARDS large animals shown on the right. And what they're doing on the right with the ARDS is they're comparing a PEEP. The top graph is the intermittent positive pressure ventilation, and the lower graph on the right are the pressure. They're both pressures over time with this new airway pressure release ventilation, in which you would extend the pressure application for longer periods of time during inspiration and have a very short expiration. So what they were doing is saying, we're going to keep that pressure up for a longer period of time because we knew that mean airway pressure correlated with oxygenation. And we're going to keep it less than it would go with intermittent positive pressure ventilation. But the problem is the intermittent is getting rid of CO2 every time it comes out. CO2 is coming out. And if we're going to oxygenate with a lower pressure sustained, then we got to get rid of CO2. So we're going to have intermittent short expirations to get rid of the CO2. And what they showed is that they could adequately ventilate and oxygenate these animals with a lower peak pressure. This was the start, and it's very different in 2020. It's become much more sophisticated. We've learned a lot of things about airway pressure release ventilation, but the concept, now these large animals were not spontaneously breathing. In fact, I've seen this paper misquoted so many times by people assuming that these were spontaneously breathing, but there was no spontaneous breathing in these large animals. Now, airway pressure release ventilation is available on most ventilators, Servo, GE, Drager, Puritan, Bennett, and Hamilton. And this is the pressure over time waveform in which you can, oops. So here is that sustained pressure application called, the P high is the pressure, and the T high is how long you hold it before this short expiration, which is called time low, or pressure and the pressure low. And what this allows you to do is to eliminate CO2. And here, this shows that you can have spontaneous breathing, shown here. You can see the pressure goes down with the spontaneous inspiration and then back up with expiration, just like you would expect. And then here's another short expiration. When this ventilatory mode is used for ARDS, that short expiration has become affectionately known as
dumping.
Dump, or dump time, or dump, because it's there to dump CO2. And when you spontaneously breathe, as it works out, not only do you enhance oxygenation if you allow spontaneous breathing on the top of the high pressure. And when I say allow spontaneous breathing, allowing it is not set on the ventilator. All the patient has to do is breathe and they're allowed. So if you heavily sedate or paralyze, as we have done some of our COVID patients that we used APRV in, but this mode, one of the things that it is thought to be potentially beneficial for is the spontaneous breathing, because you always get better matching of ventilation and perfusion with spontaneous breathing. Now, when I guess when I was a resident and a fellow, the fad at the time was inverse ratio ventilation for ARDS. It was a similar concept in that the higher you kept the mean airway pressure, the more you enhanced oxygenation. So you would do it by taking a normal IE ratio that might be 1 to 2 to 1 to 3, 1 part inspiration, 2 or 3 parts expiration, and you'd extend the I so until you reversed it and you had longer inspiratory than expiratory time. This particular graphic shows it with pressure control ventilation. You can see the pressure over time on the top and the flow over time on the bottom. And remember that pressure control ventilation, and we'll talk more about this within the next month or so, it delivers the breath with the pressure gradient. So you open the inspiratory valve, you immediately pressurize and achieve a high set pressure at the inspiratory valve, and the pressure is lower in the patient at end expiration. And so you create a gradient for putting the breath into the patient, and that's called pressure control. There are 2 pressure control breaths. One's pressure control, the other's pressure support, but they both have the same concept of moving air based on pressure gradient. And you can see the classic decelerating flow on that second row during inspiration with pressure control. And that decelerating flow is because of the pressure gradient. So as inspiration progresses, the pressure rises in the patient, and the flow decreases because the pressure gradient for flow decreases. But here you can see that the way you do pressure control inverse ratio ventilation is typically to just prolong the eye time, because inspiratory time is an independent variable with pressure control. It's the mechanism by which it cycles, and it's directly set. So with the pressure control breath, your independent variables are your set applied pressure and your inspiratory time. And therefore, flow becomes a dependent variable based on what's going on in the patient from a pathophysiology standpoint, from an inspiratory effort standpoint. But here, it's very simple with pressure control. Since inspiratory time is an independently set variable, you can just directly set the eye time with pressure control. And what happens is if the pressure rises over time until it equals the pressure you're applying, it's just going to sit there until you get to that inspiratory time, because that's an independent variable and that's the cycling mechanism. The other way that inverse ratio ventilation was done was with volume ventilation. And here, if you look at that, I'm going to have to verbally be the pointer. If you look at the V dot on top, that's flow. And remember, with traditional volume ventilation, it's flow controlled. Flow is an independent variable. You set the flow, and the flow then determines the inspiratory time because it is volume cycle. And here you can see there are two ways to prolong inspiratory time with volume ventilation. I'm looking at the top. You can either lower the flow rate, and therefore it takes longer to get to that volume where it will cycle, or you can put an inspiratory hold in. And so if I want my inspiration to be 2 seconds or 2.5 seconds, and it only takes 1.5 seconds at my set flow to reach that volume, then I'll just add the inspiratory hold on the back end to get to 2.5 seconds to achieve whatever inspiratory time I want to achieve. And you can see that if you use the second method shown in the second breath of an inspiratory hold, that you achieve a higher pressure over time with the inspiratory hold than you do by just setting a lower flow rate. So going back, a lot of people like to think of airway pressure release ventilation as just high continuous positive airway pressure, or CPAP, with occasional releases. Particularly if you're allowing spontaneous breathing, it really is like CPAP. If you set someone on CPAP of 20 or 25 and just let them spontaneously breathe, as you can always do with CPAP, it's going to look very similar to this. You just don't have the release time, you don't have the dumps, you don't have that second piece, because you're relying more on the T-low to produce your CO2 elimination than you are your spontaneous breathing. Whereas if you're using CPAP straight out and let spontaneous breathing occur, you're depending on the patient's inspiratory effort to drive oxygenation. Here, you're ratcheting up that CPAP, you're using mean airway pressure to drive the oxygenation, and then compensating for the decreased ventilatory capability, even with spontaneous breathing, with the dump to T-low. This is a point I made earlier. This just reinforces it visually. With controlled mechanical ventilation, meaning the patient is not triggering and not assisting, the positive pressure is applied passively And when that happens, it tends to go to the non-dependent areas more than the dependent areas, because there's less impediment to flow based on the abdominal contents and what's on the other side of the diaphragm to resist. There's less impediment to pushing out with the upper, and that's not good because perfusion is a dependent phenomenon primarily, so you don't get as good BQ matching. Whereas with spontaneous breathing, the diaphragm is what is driving the distribution of the tidal volume, and there it tends to go more dependent than non-dependent, so you get better match with perfusion. So that's why spontaneous breathing gives better BQ matching. This is another concept that's very important for airway pressure release ventilation, which is if you sustain a positive pressure application for longer and longer periods of time, you take advantage potentially of communications between alveoli called the pores of Kohn. So you can alveoli that are difficult to fill over time may fill by communications between alveoli, even if there's a problem filling them more proximally from their own individual private entrance to their air sac. So when you think about what produces oxygenation with APRV, it's the sustained application of P high to increase mean airway pressure. It's spontaneous breathing if you allow it, and you don't have to. I don't think it's ever a major big time contributor to oxygenation, but it's more like a boost. And with positive end expiratory pressure with ARDS, because PEEP determines how much open lung that you have for oxygenation by preventing collapse of lung at the end of expiration. And CO2 elimination occurs from spontaneous breathing. That's always a tough one because when you say, well, how can you eliminate CO2 breathing at the top of P high? It doesn't make any sense, but it happens because the breathing at the top of P high pushes CO2 more proximally, and that CO2 then is a lot easier to get out of the lung. And we'll spend a little time on this because I think it's the fatal flaw of use of APRV, which is not understanding that the therapeutic PEEP, which is the total PEEP, is created with APRV totally by auto-PEEP. So your therapeutic PEEP is pure auto-PEEP, and nothing makes that example better than when you see that we've set the PEEP to 0 in these ARDS patients. And as you know, if you wanted to do an experiment on killing an animal or a human with atelecta trauma and lung injury, there'd be no better way to do it than set your PEEP at 0 with ARDS. So obviously, if you look at that, you say, well, that can't be right. It isn't right because we're using the auto-PEEP to determine our total PEEP and our therapeutic PEEP, and we'll talk more about that. So initial APRV settings, there are a lot of choices here, not a lot of science. P high, the high pressure, either at the previous plateau pressure, if the patient had been paralyzed, or previous mean airway pressure in the non-paralyzed. And they both make sense. If you set it at the previous mean airway pressure, that is almost totally the mean airway pressure you're going to get, because that's the pressure that's going to sit there, except for that one little tiny dump time. The T high, the high on time, the time on high, 4.5 to 6 seconds, 10 to 12 cycles a minute. And the P low at 0, that's another important thing to understand. You'll read papers about APRV when you'll see that some people have used a PEEP setting on the ventilator of 5. Now, can you think of why you might choose 5? Because you're scared of 0. So it's not going to go lower than 5. If you set it at 5, you know that you're not going to totally collapse that ARDS lung, but you'll partially collapse it because 5 is not a good PEEP, therapeutic PEEP for ARDS. What's the downside of using 5?
Lower gradient for
the lower gradient for flow. So it's going to take longer to get the same amount of CO2 out with that higher PEEP. And T low, 0.3 to 0.8 seconds. And we're going to talk a little bit about, I think that the predominance of the literature right now, the evidence-based literature based on animal studies, tells us how we should set T low. I'm going to do a little diversion just because I know I got some new fellas in here, and this is a concept I want you to understand. This is a pressure over time waveform from an intubated patient breathing spontaneously through the ventilator circuit with 0 pressure support applied. Which one of the following is most correct concerning the description of the mode of breathing shown? It is continuous positive airway pressure. It is positive end expiratory pressure. It is both. It is neither. So it's both. I didn't get a chance for you to show how smart you are. So here, the pressure is always above 0. So it's continuous positive airway pressure. And the pressure at end expiration, just before the next inspiration, remember that this patient's spontaneously breathing. So when they breathe, it's going to drop the pressure, and when they expire, it's going to go back up. So end expiration is just before the inspiration. So that is also positive. So it's both. It's also a delay building. Is CPAP a form of mechanical ventilation? It provides no ventilation at all. All the ventilation on CPAP is being provided by the patient. So putting someone on CPAP is a mechanism of dialing in a certain positive end expiratory pressure. So any use of CPAP is totally targeting the end expiratory pressure. Is it possible to have PEEP without CPAP? And the answer is yes. If you have set a PEEP that allows your patient's inspiratory effort to be so rigorous that it actually it overcomes your system pressure that you've set and actually drags it negative. If I was having elective surgery, I'd let you go into the ICU. You could put me on a CPAP of 5 or 8, and I could show you that I could drag that below the x-axis with a very strong, rigorous inspiratory effort. But you never want this. So we use the terms interchangeably. On some ventilators, it might say CPAP. On other ventilators, it's PEEP. But it's always the positive end expiratory pressure that's driving our therapy. Now, sometimes I'll have a medical student and they're just beginning to understand auto-PEEP. And remember, auto-PEEP just means that there's still air trying to get out of the lung at the end of expiration when you end the expiration and open the inspiratory valve. And that's called triggering. So remember, triggering is closing the expiratory valve at the end of expiration and opening the inspiratory valve and allowing the next breath to go into the patient. When triggering occurs, if there's still flow coming out of the patient, that is unnatural. It's unnatural. It occurs in obstructive airways disease. I think the classic poster child for auto-PEEP is a real severe status asthmaticus patient that has really tight airways and just can't get that breath out. And they have been auto-PEEP and they have high intrathoracic pressures. They may be hypotensive, they're hyperinflated. But when you set a PEEP on the ventilator, let's say we set 5, and it may be set 5 on a status asthmaticus patient, and you diagnose auto-PEEP, and you see that the auto-PEEP, in other words, the pressure at the end of expiration at the expiratory valve is based on a threshold resistor that's set in the expiratory limb, and that's how we're able to set PEEP. So if we set a PEEP of 8, the threshold resistor doesn't let that pressure drop below 8 at expiration. We set it 10. But if we set it at 5, and there's still flow coming out, like typically occurs in obstructive airways disease with acute exacerbation, we can measure the pressure rise that occurs from that flow that keeps coming at the end of expiration. So we measure that, and if your set PEEP is 5, and it measures that the pressure went up another 8 before the air stopped flowing, then you've got an auto-PEEP of 8, you've got a set PEEP of 5, you've got a total PEEP of 13, and the total PEEP is the real PEEP. And that's important when you understand airway pressure release ventilation. And back to my medical student, if the medical student would say, well, Dr. Dellinger, you just showed us that we diagnosed this auto-PEEP of 8 in this asthma patient. How do we treat that? How do we treat that auto-PEEP? How do we make it go away? And I can say, well, I'll just go over and put my set PEEP at 10, and I've already reduced the auto-PEEP to 3, right? What did I do to my total PEEP? My set PEEP, I increased, that decreased my auto-PEEP. But it's still, the total PEEP doesn't change. And that's the concept with airway pressure release ventilation. It's the total PEEP that counts. So as far as the therapeutic PEEP that's generated, whether you used a PEEP of 5 or a PEEP of 0, you could still achieve the same total PEEP, whether it's 0 or whether it's 5, because it's set PEEP plus auto-PEEP. Since we usually set the PEEP to 0 with APRV, our therapeutic PEEP is totally auto-PEEP. And the auto-PEEP is determined by our T-low, how long we let that dump occur, and the P-high, P-low gradient, which determines how high the flow rate is. Atelectasis can develop in seconds in critically ill patients with ARDS lung. You can see that demonstrated in animal experiments. So let's talk about the concept of setting T-low. This is just showing you expiratory flow. So what you're looking at is the start here. You're looking at the start of the dump, right here where my pointer is. And here's the end of the dump. So this is T-low. And this is the peak expiratory flow, and that has to occur at the very start of expiration, because that's when your gradient is high. You've got your P high and you've got your 0 typically. So the flow is going to be greatest at the start of expiration, and then it's going to decrease over time as you depressurize that P high application. And you can see that, here you can see that this T-low occurred at about what percent you think of that initial peak expiratory flow?
50%.
About what?
Looks like 50.
50. It looks like 50. And here, this T-low gave what percentage of the initial peak expiratory flow, you think?
Closer to 75.
Yeah, maybe about 75%. And this T-low gave what percent? 0. So the flow went to 0. That meant that you just totally went back to atmospheric pressure, which we said is bad. We did pretty good guessing. They said 70%. The other thing to note about the expiratory flow pattern is that it is dependent to some degree on the severity of the ARDS. So if you have more severe ARDS, what's going to happen to your lung compliance? Decreases. What happens to your lung elastance? Increases. What happens to your elastic recoil? Increases. So you would anticipate that a higher the slope, the steeper that slope is, it tells you something about your ARDS. So if you're treating a patient with bad ARDS, over time you will notice a change in that slope, and the less acute that angle is, the more compliant your lung has become, and you are decreasing elastance and improving compliance. Now this slide is, you have to strain a little bit to see this slide, but the bottom graph is just a reproduction of the one that I had just shown you. The top one is a nice illustration. Do you see that green line? That green line is there to show you that the pressure that you're seeing on this particular type of display screen is the pressure out at the ventilator. It's not the pressure in the alveoli. So if you were actually measuring alveolus pressure, which you can't do, you would see at the end expiration is considerably higher than what you're seeing out with the ventilator graphics, and that's because of the auto-PEEP. So now I'm going to talk about time-controlled adaptive ventilation, which is airway pressure release ventilation that has a specific protocol applied to it. And that protocol is purely and simply that you set your T-low to 75% of your initial peak expiratory flow rate. And then over time, you keep adjusting T-low to keep it at 75%. And that particular setting has been shown in numerous animal models to produce optimum stress and strain on the lung and would appear to be applicable to humans, although there's no human studies. When you pick up just someone's got a blog or posting or whatever talking about APRV, you'll often see it listed from 50 to 70% or 50 to 75%. But I think I'm becoming more and more convinced based on animal data that the 75% is perhaps the best way to set it. This is one of our COVID patients, a 34-year-old male with COVID-19 ARDS, compliance 9 mLs per centimeter water. You can see that white lung. The application of time-controlled adaptive ventilation to this patient, again going back to the communications between the alveoli, and it creates a viscoelastic lung, meaning that the lung sort of fills, and then if you keep pressing on it, it eases over here, and it's sort of like a sponge-like thing, and then when it expires, you get like a quick exit of air from those parts of the lung that are open and have quick expiratory time constants. So you get an initial rush, and then it's slower. So what this shows you is that long inspiratory time. Just look on the left. But you can see that red curve on the left. You get a lot of recruitment initially when you first apply a high pressure, and then you continue to recruit lung over time. And then with expiration, you get a fairly rapid de-recruitment of lung, and then it becomes slower. And the trick is to have a short expiratory time so you don't lose a lot of that recruited lung. This is one of multiple animal studies. If you look across the top, you can see going from right to left, it's APRV with a 75% ratio, then PEEP of 16, then APRV with the ratio going down to 10%, and then PEEP of 5. The yellow is open lung, and the red is closed lung. And here you can see that there's more open lung at the APRV with the peak flow PFR ratio of 75%. And then here, Here is histology, again looking at end expiration, with the blue now representing open lung, and control it's all open, and once again showing that APRV 75% in this study, histologic study, gave more open lung. Guidelines for initial settings, P high, maybe 30. If you're going to let the patient spontaneously breathe, you need to account for that in choosing your P high, because volume trauma is based on transpulmonary pressure. It's not just based on your peak or plateau pressure in your ventilator. So if you're going to let your patient have inspiratory effort, that negative component that the patient adds on the top of P high contributes to the transpulmonary pressure, and it's transpulmonary pressure that drives volume trauma. So if you set your plateau pressure at 30, set your P high at 30, and let your patient spontaneously breathe, by definition, you're already exceeding the transpulmonary pressure that we think is safe, because you've added that negative to the 30. So it would be like having, if your patient is pulling -6, it would be like having a 36 on a plateau pressure in a patient that is not assisted. T high at 5 seconds, P low at 0, and end expiratory flow at 75% of initial peak flow. Start probably at 0.5. These are just some quick examples. Spell the border. So this is a patient that's not spontaneously breathing. This is P high and T high. Here's the pressure. Here's the time. Here's your dump. Here's your peak. And then this is what spontaneous breathing looks like. This is on P high. You see it goes down with inspiration, up with expiration, down with inspiration, up with expiration. And then here is, if you, some people have put pressure support in for spontaneous breathing on P high, again, with the same concerns that you may be generating transpulmonary pressures that exceed safe ventilation when you start adding pressure support on P high and allowing patient inspiratory efforts. So, as far as weaning APRV, you decrease the P high over time and slow the respiratory rate down and add pressure support. So it's slowly converted from APRV to CPAP and pressure support.
Dr. D, so it's so the drop and stretch method is basically you drop your P high and you prolong your T low. Is that basically?
No, you prolong your T high. So you shorten the dump. You just slowly eliminate the dumps.
Okay, so drop your P high and drop your T high. You shorten your
drop your P high and
extend your
T high. And so it's really, when you take your last dump away, it now is just purely and simply CPAP. And by then you've started allowing spontaneous breathing and even in the addition of pressure support. So it really converts to pressure support.
Mm-hmm.
Limitations of APRV is the effect of spontaneous breathing on transpulmonary pressure and calculating auto-PEEP, total PEEP, and driving pressure. When everything started happening with driving pressure, there's a series of publications with people figuring out how you, on some of the ventilators, not all, you can do expiratory holes, and you can actually measure auto-PEEP and therefore total PEEP and therefore calculate driving pressure. I haven't seen that capability on any of the ventilators that we have here with APRV. I think it's mainly the Draeger that has that capability. And I wanted to mention one paper before we quit. This is the only randomized controlled prospective trial of APRV published in 2017 out of China. Included ARDS patients with a PaO2-FiO2 ratio less than 250, intubated less than 48 hours, no severe COPD, no refractory shock, no intracranial hypertension. Randomized 138 patients, mostly pneumonia-induced ARDS, followed by pancreatitis, sepsis, and averaged 24 hours on the ventilator. Used a ARDSNet-like traditional ventilation, low tidal volume strategy versus APRV. 71 and 67 patients with rather dramatic results. Their primary endpoint was ventilator-free days alive and not getting ventilator support. And you can see there were a mean or median of 19, and the airway pressure release ventilation on to, the mortality difference, 20% with APRV, 34% with traditional, less trachs, more successful extubations. Sort of typical, too good to be true type results, I think. This is going to be really hard for you to see. But over time, the plateau pressure went down in the APRV group. The mean airway pressure went up. The compliance improved, and oxygenation improved. And norepinephrine requirements were about the same. Notice the RAS score in the APRV group is lower. Remember, a RAS score goes -2 to -4. -2 is probably optimal. Patient wakes up with stimuli, and then within 10 seconds goes back to being sedated. One of the limitations of this study was it's a single center, could not be blinded. There were more comorbid organ dysfunctions in the low tidal volume group, so they were handicapped. The low tidal volume group did poorly on weaning with extubation percentages very low. The sedation, there was no sedation protocol in the low tidal volume group, but there was a sedation protocol in the APRV group targeting allowing the right amount of spontaneous breathing. So some of these results may have been from more appropriate sedation in the APRV group. Potential contraindications to APRV is large bronchopleural fistulas, because there you're holding that high intrathoracic pressure for long periods of time. So air is just streaming out of the bronchopleural fistula. And severe obstructive airways disease, because the dump doesn't work very well if you have bad obstruction. And some of these slides I got from some Alabama-owned website postings, and also from Josh Farkas. A couple of these came from pulmonarycrit.org. Thank you.
Questions? Yeah. Sometimes they say you can't use it on paralyzed patients, but I
Again, the original study was done on paralyzed patients. I think that people got so into the potential advantages of spontaneous breathing on P high that it sort of became a mindset. Yeah, I would say I have used it more often on paralyzed patients than I have on non-paralyzed patients, the really severe ARDS patients. Because the holding, increasing lung opening and keeping it open, it to me is the hallmark of this mode. The spontaneous breathing is sort of like, you know, special feature on the new car that you like.
Yeah, it was the original paper was Downs did it on pigs that were paralyzed.
Yeah, I showed them briefly.
Yeah.
I didn't tell them what the large animal was.
But they should know that anesthesiology invented 2 modes of mechanical ventilation. That's something else.
Yeah.
What is your personal approach for when you're initiating use of APRV? Because we, in general, we don't use it that commonly. And what do you find are kind of like more ideal patients versus, you know, barriers to use?
I think patients that you're just having a difficult time oxygenating and you'd like to try to see if you can't get more lung recruited with that long sustained pressure application. And also the mean airway pressure changes aren't a big ticket for oxygenation, but it does improve. You do increase oxygenation by increasing mean airway pressure. It's just not a big ticket variable, but you will get some benefit from the higher mean airway pressure just from driving oxygen into the blood. But the main reason to apply it is that you're hoping that sustained mean airway pressure will open up lung. And there's no, you know, you could start out almost anywhere with their P high. I mean, you don't want to start out real low. You know, if the patient's not spontaneously breathing and they have normal body habits, if you just go straight to 30, you're at the max okay P flat pressure. Because with normal body habitus, your P high is going to be the plateau pressure that we would look at to tell whether we're safely ventilating or not. If you were going to allow spontaneous breathing, I wouldn't start that high. If you wanted spontaneous breathing, I'd start considerably lower, maybe something like 24, 22.
What kind of tidal volumes did you see during the COVID era on the setting?
Yeah, so, you know, that's something that should be in my talk that's not, which is we didn't talk about the exhale volume. So your exhale volume that accompanies that expiratory time that we spent a lot of time talking about, that is your tidal volume, because the air that comes out that you're measuring during that expiration, that dump, when you repressurize back to that same pressure, that's the tidal volume that's going back in. Make sense? Out, repressurize to the same pressure, puts it back in. So that tidal volume, the one that you're measuring, the exhale tidal volume, is your tidal volume that you would correlate with low tidal volume strategy. So you certainly would not want that to be too high. You know, like you would typically like it to be 6 mLs per kg or less. To answer your question, I think when we used the APRV on some of the ECMO patients, it was some of the patients that had some of the worst compliance. So their tidal volumes were probably around, yeah. I'll call you back in about 4 or 5 minutes. I'll call you back in about 4 or 5 minutes. Okay. That's not true. So their compliance was pretty bad, and they were also on ECMO, so we didn't have to worry as much about CO2 elimination.
So that was actually one of my questions. So if your P high, you don't allow spontaneous breathing, your P high is, below 30, and somebody who has a relative normal BMI, you still are aiming for low tidal volume ventilation. You're not going to go up to 8 cc's per kg. You still want 6 cc's
No,
per
because
kg.
that is part of your mechanical power formula. So if you were looking at mechanical power and you plug this in, and mechanical power is thought to be, at least this week, on what may be the most important variable for ventilator-induced lung injury, the tidal volume is an important part of that formula, as is transpulmonary pressure.
And have you ever tried, I can just keep going on with these questions, so if you guys have other questions, let me know. Have you ever tried to raise your P low higher to limit your tidal volume? So
that would work. The only problem with that is it'll decrease your expiratory flow and decrease your CO2 elimination. But certainly that would be a way to, that would be a way to do it. So if you wanted to decrease the tidal volume that's going back in, you decrease the tidal volume that's coming out. And you can do that by lowering P high, because that's the upstream pressure for flow. Raising the P low, because that's the downstream pressure. Or shortening T low, and then you get less time for flow out.
In the morbidly obese, what will you do with your P high?
Well, you just allow a much higher P high, and as you know, if you don't have an esophageal pressure monitor to estimate pleural pressure, it's hard to know how much of that plateau is compartmentalized toward pushing out the chest wall and pushing the abdomen down. So you're sort of guessing in the absence of having esophageal pressure measurement. So I typically say, sort of like, that when you let it be higher, and you look at how obese your patient is and say how much of that pressure is pushing out chest wall and abdomen versus pushing out lung. Because you're not concerned, obviously, about the component of that that's pushing out chest wall and abdomen.
And why? And what's the difference if you're paralyzed between APRV and inverse ratio ventilation?
Probably very little.
It's the spontaneous breathing that gives you.
It would be essentially the same. If you set up inverse ratio ventilation and had the same set PEEP on your inverse ratio ventilation as you do total PEEP on your APRV with the auto-PEEP, those should be almost identical, because you would get the same push, 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 push for a long time, and then back to that same positive end expiratory pressure, and then back in again. It's with reverse IE, it's still going to be not as sustained a P high relative the IE ratio, if you calculated it, if you say you had 10 cycles with a 0.5 on the dump, so that's 5.5 times 10 is 55, and 0.5 times 10 is 5. So your IE ratio there is over 10 to 1.
It ends up being relatively simple.
Similar, but it's actually even more reverse.
Yeah, more. There's never going to be a mode of ventilation that proves superior than another mode of ventilation in a large trial.
Chinese thing.
So,
Okay, I'm gonna go get that conference call. Y'all have a good
Thank you.